A 7-year-old woman named Sylvia came to me 16 months ago. She had been a senior accountant for 38 years. Precise, detail-oriented. The kind of woman who noticed discrepancies in financial reports that 3 other people had reviewed and missed. She noticed things. It was the foundation of her professional identity, and yet she had spent 14 months not understanding what her own brain was showing her 4 or 5 times every month. It began with her vision. She would be sitting at her desk, or reading, or watching television, and a small area of her visual field would begin to shimmer. Not blur, a crescent of flickering light, like looking at heat rising from summer tarmac that would appear at the edge of her vision and slowly expand over the course of 20 to 30 minutes before drifting to the periphery and disappearing. Sometimes the shimmer was accompanied by a brief period where she could not read. The words in the center of her visual field would seem to dissolve, to become temporarily inaccessible. Before returning as the visual disturbance passed, sometimes her right hand would feel strange for 5 or 10 minutes. Not painful, strange, slightly numb, slightly not quite hers, and then normal again. She had seen her optician twice. Both times her visual acuity was unchanged and her retinal examination was normal. She had been told her eyes were fine. She had been told she might be experiencing ocular migraines and that if she was not getting headaches, they were nothing to worry about. She had accepted that explanation because the events were painless, and because they resolved, and because the optician had used the word migraine in the same tone most people use the word common, implying ordinary, implying manageable, implying that the appropriate response was to note it and continue. What Sylvia did not know, what nobody had sat down and specifically explained to her, was that what she was experiencing was not a harmless visual curiosity. She was experiencing a transient aura without headache, a silent migraine, and 2 of her episodes in the past 4 months had produced a focal neurological symptom. The strange right hand that should not have been filed under nothing to worry about without imaging of her brain and a formal neurological assessment. Because the visual and sensory disturbances of a migraine aura and the neurological symptoms of a transient ischemic attack can be clinically indistinguishable in the consulting room without specific investigation. And in a 7-year-old woman with a 15-year history of managed hypertension, the two require specific and urgent differentiation. Sylvia's MRI showed no current ischemia. Her MRA magnetic resonance angiography showed no significant stenosis in her cerebral vessels. She did not have a TIA. She had migraine with aura, without headache, a real, documented, neurological condition with a specific biological mechanism, a specific risk profile, and a specific management pathway that her optician had not had the capacity to provide, and that her GP had not yet been formally involved in. And crucially, she had a condition that itself, independent of the stroke question, carries a doubled risk of ischemic stroke compared to the general population. A risk that modifiable factors in her daily life were actively amplifying. A risk that nobody had mentioned because the word migraine had ended the conversation before it needed to continue. I'm Dr. Kevin Adewale. I'm a cardiothoracic surgeon. I spent over 30 years operating on hearts, repairing arteries, and watching what happens when the vascular system that feeds the brain is under stress in ways that announce themselves through symptoms the brain produces and the person cannot interpret. What I'm about to share with you, most doctors won't bring up at your annual checkup. But after 60, it matters more than you think. Today, I'm going to explain silent migraines. Migraine with aura without headache. I am going to tell you what the aura is, what is actually happening inside the brain when it occurs, why it is so consistently misunderstood and underinvestigated, what the genuine risks associated with it are after 60, and what the correct management approach looks like for someone experiencing it. So stay with me, because the risk connection I'm going to describe in the middle of this video is the one that most people experiencing silent migraines have never been told about. And it is the connection that makes the difference between managing this condition informedly and carrying a risk you do not know you have. Before I explain the silent migraine specifically, I need you to understand what a migraine aura actually is, because most people understand migraine as a headache, a severe, disabling, often one-sided headache accompanied by nausea and light sensitivity. That understanding is accurate for migraine with headache, but it describes the pain phase. It does not describe the aura. And the aura is not the warning sign of the headache. The aura is a neurological event in its own right. It can occur with or without the headache that follows, and when it occurs without the headache, as it increasingly does in adults over 50, for reasons that are biologically specific and worth understanding, it produces a collection of neurological symptoms that arrive without pain, resolve without pain, and are therefore consistently underreported, underinvestigated, and under-recognized as the significant neurological phenomenon they represent. Think of it this way. Your brain is an electrochemical organ. Every thought, every perception, every sensory experience, every movement you make is produced by the precisely coordinated firing of billions of neurons communicating through electrochemical signals. That coordination is maintained by a careful balance of excitatory and inhibitory influences on the neural networks responsible for each function. In a migraine aura, that balance is disrupted by a phenomenon called a cortical spreading depression, or CSD. Despite the name, cortical spreading depression has nothing to do with emotional depression. It is a wave of electrochemical disruption that spreads slowly across the cortex of the brain at a rate of approximately 3 to 5 millimeters per minute. As that wave passes through a given region of the cortex, the neurons in that region first fire intensely, producing the positive symptoms of the aura, the shimmering lights, the tingling, the strange sensations, and then fall silent, entering a period of suppressed activity that produces the negative symptoms, the blind spot, the numbness, the inability to find words, before recovering and returning to normal function. As the wave moves on, that wave moves at the rate at which the visual, sensory, and language symptoms of an aura evolve. Slowly, over 20 to 30 minutes, spreading from one area to the next, in a sequence that reflects the geography of the cortex. The shimmer that begins at the center of vision and expands to the periphery over 30 minutes is cortical spreading depression, moving from the primary visual cortex outward through the surrounding visual association areas. The hand tingling that moves from the fingertips to the wrist to the forearm over 15 minutes is the CSD wave moving through the somatosensory cortex in exactly the sequence in which the body surface is mapped there. The evolution is the signature. It is what distinguishes migraine aura from stroke. Stroke produces neurological deficits that arrive suddenly and are maximal at onset. Migraine aura produces symptoms that evolve gradually over minutes as the CSD wave spreads. That distinction is clinically critical, and it is the distinction that requires neurological assessment to apply correctly. When the clinical picture is ambiguous, here is why migraine aura without headache is so specifically common after 60, and this is the part that most people experiencing it have never been told. In younger adults, migraine aura is almost always followed by headache. The relationship between the aura and the pain is reliable. The aura is the warning, the headache is the event, the two travel together. But as adults age, particularly in women after menopause, whose migraine patterns change significantly with the shift in estrogen levels, the headache component of migraine tends to decrease in frequency and intensity while the aura component continues. The brain continues producing the cortical spreading depression. The trigeminal vascular activation that produces the pain component of migraine attenuates with the hormonal changes of menopause and with the natural age-related changes in central sensitization pathways. The result is aura without headache, the neurological event without the pain that would normally make the neurological event impossible to ignore. That separation of aura from headache is a specifically dangerous feature of migraine in older adults, not because the aura itself is necessarily more harmful in isolation, but because the absence of the headache removes the symptom that would reliably prompt medical attention. The headache demands assessment. The painless shimmer gets shown to an optician. The painless hand tingling gets attributed to posture. The painless visual disturbance gets filed under nothing to worry about, and the neurological event and its associated vascular risk continues without the clinical investigation it requires. Here is what is actually happening inside the brain during the cortical spreading depression of an aura. The wave of neuronal depolarization is not simply an electrical event. It is accompanied by significant changes in the local cerebrovascular environment. As neurons depolarize, they release potassium ions and glutamate into the surrounding extracellular space. Those compounds alter the tone of the pupil arteries, the small blood vessels on the surface of the brain, causing an initial brief vasodilation followed by a more sustained vasoconstriction. Blood flow to the affected cortical region falls during the suppression phase of CSD, not dramatically, not to ischemic levels in most cases, but to reduced levels that alter the oxygen delivery to the tissue involved. And in a brain over 60, where the cerebrovascular reserve is already reduced by age-related arterial stiffness, where the autoregulatory mechanisms that maintain cerebral blood flow against pressure changes are less precise than at 40%, that transient vascular disruption operates with a narrower margin of safety. Research from the American Academy of Neurology confirmed that migraine with aura was associated with a twofold increased risk of ischemic stroke compared to the general population, a finding that was independent of other cardiovascular risk factors and that was specific to migraine with aura rather than migraine without aura. Twofold. The aura is the variable, not the headache. The headache carries no stroke risk signal. The aura does. And in adults over 60 who are experiencing aura without headache, that risk signal is present without the clinical flag that would normally draw attention to it. That sounds alarming. I want to be precise. A twofold elevation in relative risk is not the same as a high absolute risk. The absolute risk of stroke in people with migraine with aura who have no other cardiovascular risk factors remains relatively low, but the risk profile changes significantly when migraine with aura coexists with other cardiovascular risk factors, with hypertension, as in Sylvia's case, with smoking, with the use of combined oral contraceptive pills in younger women, with obesity, with atrial fibrillation, with diabetes. Each additional risk factor amplifies the baseline aura-associated stroke risk in ways that make the combination clinically significant. Let me ask you something directly. Have you been experiencing visual disturbances, shimmering crescents, zigzag patterns, blind spots that appear and resolve over 20 to 30 minutes, with or without headache? Have you been attributing them to eye strain, to needing new glasses, to screens? Has anyone ever used the word aura in your clinical consultations and explained specifically what that word means for your stroke risk? Tell me in the comments, because the number of adults over 60 experiencing migraine aura without headache who have never had a formal neurological assessment, who have never been told about the stroke risk association, and who have never had their modifiable cardiovascular risk factors reviewed in the context of their aura episodes is a number that I find genuinely troubling. And it is a number that this video exists to reduce. The fourth thing I want you to understand about silent migraine is the differential diagnosis problem. And this is where the clinical stakes are highest and where the most urgent action is required. The symptoms of migraine aura and the symptoms of a transient ischemic attack share significant clinical overlap. Both can produce transient visual disturbances. Both can produce transient focal sensory symptoms. Both can produce transient speech disturbance. Both resolve within an hour. Both leave no lasting deficit in most cases. And the distinction between them, which determines whether the person needs migraine management or urgent stroke prevention, cannot reliably be made from symptoms alone in an older adult presenting for the first time with a painless neurological episode. Here is what actually distinguishes them biologically. Migraine aura evolves gradually. The symptoms spread and develop over minutes as the cortical spreading depression wave advances. A visual aura that takes 25 minutes to move from the center to the periphery of the visual field is showing you the CSD wave in real time. A TIA produces neurological deficits that are maximal at onset. The hand goes numb all at once. The vision goes dark without a spreading phase. That distinction is real and diagnostically valuable, but it requires a detailed history taken by someone who knows to ask about the evolution of symptoms, whether they spread over time or arrived all at once, and who can interpret the answer in its neurological context. An optician examining a normal retina after the episode has resolved cannot make that distinction. A GP in a 7-minute appointment who has not heard of cortical spreading depression may not have the framework to apply it. A neurologist can. A stroke physician can. And after 60R, a first episode of painless, transient neurological symptoms requires assessment by someone who can. Research published in JAMA Neurology found that approximately 20% of adults over 60 presenting with transient neurological symptoms consistent with migraine aura had evidence of acute cerebral ischemia on diffusion-weighted MRI, the most sensitive imaging for early stroke, indicating that what appeared clinically to be aura was in a significant minority of cases actually a TIA or small stroke, 20%. 1 in 5, not diagnosed without imaging. Not distinguishable from symptom description alone, only identifiable with the scan. This is not a reason to assume that every aura episode is a TIA. It is a reason to ensure that the first episode of painless, transient neurological symptoms in an adult over 60 receives imaging and neurological assessment before it is categorized as migraine and filed as nothing to worry about. Once imaging has confirmed no ischemia and the history clearly fits migraine with aura, subsequent episodes can be managed accordingly. But the first episode, or any episode where the symptoms include new focal neurological features such as limb weakness, speech disturbance, or confusion, requires emergency assessment rather than reassurance. Here is what is actually happening in the clinical encounter where this distinction is missed. The adult over 60 describes a visual disturbance that lasted 20 minutes and resolved. The clinician, hearing the resolution and the absence of headache, applies the label ocular migraine or silent migraine and provides reassurance. The label is not wrong. The reassurance without imaging is because the resolution of symptoms does not exclude ischemia. A TIA resolves. A small cortical infarct may produce transient symptoms that resolve as surrounding tissue recovers. The resolution is common to both. What is not common to both is the imaging finding, and the imaging finding is the only thing that distinguishes them with the certainty that the clinical stakes require. The fifth thing I want to address is the management of confirmed migraine with aura after 60, because once ischemia has been excluded, the management conversation has two distinct components: the management of the aura episodes themselves and the management of the cardiovascular risk that the aura association signals. And both of those components are specific and actionable. Neither of them is nothing to worry about. For the aura episodes themselves, the management focuses on identifying and modifying triggers. Migraine triggers are well documented and individually variable. In adults over 60, the most common triggers for aura without headache include disrupted sleep, either insufficient sleep or oversleeping beyond the normal pattern. Irregular meals and extended fasting periods, which cause glucose fluctuations that alter the threshold for cortical spreading depression. Dehydration. The single most consistently identified modifiable migraine trigger across all age groups. Alcohol, particularly red wine, which contains vasoactive compounds including histamine and tyramine that lower the CSD threshold. Bright or flickering light, including screens at high brightness in dark rooms, sunlight reflecting from water or glass, or fluorescent lighting. An emotional stress, not because migraine is a psychological condition, but because the stress response alters cortical excitability through the same neuroendocrine pathways that regulate CST threshold. A migraine diary, a consistent daily record of sleep, meals, fluid intake, stress level, and aura episode occurrence maintained over 8 weeks provides the pattern recognition that identifies which triggers are operationally relevant for any given individual. That diary is the most important diagnostic tool in migraine management, and it costs nothing beyond the commitment to maintain it consistently. For the cardiovascular risk component, the management is specific to the risk profile of the individual. Hypertension must be controlled in adults with migraine with aura and hypertension. The target blood pressure is the same as in any high-risk cardiovascular patient, below 130/80. Some anti-hypertensive medications, specifically the beta blocker, propranolol, and the calcium channel blocker, verapamil, have evidence for migraine prevention as well as blood pressure control and may serve dual clinical purposes in this population. The combined oral contraceptive pill is contraindicated in women with migraine with aura due to its false amplification of the stroke risk, a contraindication that applies at any age but becomes particularly important to revisit in perimenopausal women who may still be using hormonal contraception. Smoking cessation is non-negotiable in anyone with migraine with aura given the multiplicative effect of smoking on the aura-associated stroke risk. An antiplatelet therapy, specifically low-dose aspirin, may be considered in adults with migraine with aura who have additional cardiovascular risk factors in discussion with their neurologist or cardiologist based on an individual assessment of the bleeding risk against the stroke risk reduction. I call this the silent aura management protocol. So 5 steps beginning this week. Step 1. If you are experiencing recurring episodes of transient visual disturbance, sensory symptoms, or speech disturbance that resolve within an hour and have not been formally assessed with brain imaging, request a referral to neurology. Do not accept ocular migraine as a diagnosis from an optician without a neurology review and imaging. The imaging is what makes the diagnosis safe. Without it, the reassurance is premature. Step 2. If you have been diagnosed with migraine with aura, with or without headache, ask your GP or neurologist specifically about your stroke risk in the context of that diagnosis. Ask whether your current cardiovascular risk factors have been reviewed in the context of the aura. Ask whether your blood pressure target is appropriate given the aura association. Ask whether any of your current medications require review. That conversation requires someone to connect the migraine diagnosis to the cardiovascular risk discussion. If nobody has connected those two things, you need to be the person who asks for the connection to be made. Step 3. Begin a migraine diary this week. Record sleep timing and duration, meal timing, fluid intake, alcohol consumption, stress level, screen time, and any aura episode, its duration, its specific character, and what preceded it in the 4 to 8 hours before onset. Maintain it for 8 weeks, then review it looking for patterns. The trigger that appears most consistently in the 24 hours before each episode is the trigger with the most leverage for prevention. Step 4. Address the 4 most modifiable triggers with specific structural changes. Fix your sleep timing, the same bedtime and wake time 7 days a week because the cortical spreading depression threshold is most vulnerable to the disruption of an inconsistent sleep schedule. Increase water intake, 6 to 8 glasses of water distributed across the day. Reduce alcohol, particularly red wine and other high tyramine beverages. Manage screen brightness, screens at eye level. Room lighting adjusted so the screen is not significantly brighter than the surrounding environment. And screen breaks every 30 minutes. Step 5. If you have migraine with aura and you smoke, please make that the singular priority of this week, not next month. This week, the combination of migraine with aura and smoking represents one of the highest modifiable stroke risk combinations in neurovascular medicine. The interaction is not additive, it is multiplicative. No migraine management is complete while smoking continues. I want to come back to Sylvia. After her MRI, an MRI confirmed no ischemia and the history clearly established migraine with aura without headache. Her neurologist reviewed her complete cardiovascular risk profile in the context of the diagnosis. Her hypertension was reclassified from adequately managed to requiring tighter control given the aura association. Her previous target had been below 140, the new target was below 130. Her migraine diary over 8 weeks identified 3 consistent triggers: disrupted sleep on weekends when she stayed up 2 hours later than usual, red wine, and extended fasting before her largest meal of the day. She made 3 changes. She kept her sleep schedule consistent 7 days a week. She stopped drinking red wine and substituted white wine on the occasions she drank. She moved her largest meal earlier and added a mid-morning snack to prevent the glucose dip that preceded several episodes. Over the 4 months following those changes, her aura frequency dropped from 4 to 5 episodes per month to 1, occasionally 2. Not eliminated, managed with information, with understanding of the mechanism, with a treatment plan that addressed the actual biology rather than offering reassurance that the painlessness made the episodes acceptable. She came back to see me 6 months after her initial assessment. She sat across from me with the particular alertness of a person who has replaced confusion with understanding. She said the most useful thing she had learned was not the treatment, it was the mechanism. She said, understanding that my brain was producing a spreading electrical wave that I could actually see moving across my vision changed how I thought about what was happening. She paused, and then she said the thing that has stayed with me since. She said it had a name, it had a mechanism, it had a management pathway. What it did not have was someone who had explained any of those 3 things to me before. Now, that is the cost of a label applied without explanation. Ocular migraine. Nothing to worry about. 2 words and a reassurance, in place of a mechanism, a risk discussion, and a management plan that Sylvia needed and was entirely capable of using if someone had simply provided it. Let me say each key point one final time. The silent aura, migraine with aura without headache, is a genuine neurological event produced by cortical spreading depression, a wave of electrochemical disruption moving across the cortex at the rate at which the visual shimmer expands, at which the sensory disturbance spreads. It becomes more common after 60, particularly in women after menopause, as the headache component of migraine attenuates. While the aura continues, it carries a 2-fold increased risk of ischemic stroke that is specific to the aura and independent of other risk factors. A risk that is amplified by hypertension, smoking, and hormonal factors. Its first presentation in an adult over 60 requires brain imaging and neurological assessment to distinguish it from TIA, because the resolution of symptoms does not exclude ischemia, and symptom description alone cannot make that distinction reliably. And once confirmed, it has specific manageable triggers and a cardiovascular risk profile that requires active management rather than reassurance. It has a name, it has a mechanism, and it has a management pathway. Now you have all 3. Which of the experiences I described today have you been attributing to something else? The shimmer at the edge of your vision, the brief strange hand, the minutes when the words on the page dissolved and then came back. Tell me in the comments below. I read every single one. And your answers tell me how many people are carrying an unrecognized neurological event that has been shown to an optician and filed as nothing when it needed to be explained. If this video gave you a reason to make a neurology referral, to start a migraine diary, to have the cardiovascular risk conversation that Sylvia needed someone to initiate 14 months earlier, share it. Not for me, for the person in your life who has been seeing shimmers in their vision every few weeks and has been told their eyes are fine. Who does not know the word aura? Who does not know about cortical spreading depression? Who has not been told that the painless disturbance they are accommodating carries a risk that deserves investigation rather than reassurance? They may not know, but you do now. And that is exactly why you are here. And if you have not subscribed yet, please do. Every week, I bring you honest, evidence-based information that I wish every one of my patients had access to long before they needed surgery. Take care of your heart. It has been working for you every single minute of every single day without asking for anything in return. Give it what it needs. It is a fair trade. One last thing, and this is important. Everything I've shared today is general medical information based on published research and my clinical experience as a cardiac surgeon. It is not a substitute for your personal medical care. If you are experiencing transient neurological symptoms, visual disturbances, sensory changes, speech difficulties for the first time, please contact your own physician or seek emergency assessment before attributing them to migraine. They know your history. They know your vascular risk profile. I do not. This is education. Use it as the beginning of that conversation. The conversation that Sylvia wishes someone had started with her 14 months earlier.